Today we're going to be discussing the new contingency component developed by NHSBT, the reduced dose apheresis platelets. And over the next 30 minutes or so, we'll hear briefly some background information about the new component, why it was necessary to develop this component, how it will be used, when it will be used, etc. And then we'll open up this session for a live Q&A. We're joined by a panel of colleagues today from NHSBT who will do their best to answer any questions that you may have today and some of the questions that were submitted in advance of today. Because today's session is only 30 minutes, we may not get around to answering all questions asked of the panel, but what we will do is send out a summary of all questions and of all the questions and answers that were discussed on this call, and include any answers to questions that were asked but we didn't get around to picking up. But we will do our best to get through as many as we can. And just finally, before we begin, just a thank you to all of you and to all of your colleagues for your support with this work. Today's panel consists of leading the panel is Dr. Lise Estcourt, consultant haematologist at NHS Blood and Transplant. We have Jane Davies, assistant head of manufacturing development, Sasha Wilson, who's a PBM practitioner, Craig Wilkes, who's lead specialist in process improvement, and myself, a patient blood management practitioner too. Very short agenda today, and we're going to open up with a very brief background into this piece of work. And with that, I'm going to welcome Dr. Lise Estcourt to open today's session.
Thank you very much, Danny. Can you do next slide, please? Yeah. So to give you a background about the reduced dose contingency platelets, they've been introduced to mitigate risk to patients and improve the blood supply during a severe platelet shortage. And the aim of this is to prevent a red alert platelet shortage being called, or to reduce the duration of a red alert platelet shortage. And what we would be doing is splitting the apheresis platelets into 3 units rather than 2, and so that will increase the supply of platelets during this period of time by around 18%. This reduced dose component will only affect apheresis platelets at the moment. As I said, it's 2/3 of the standard dose. So the specification is at least 150 × 10⁹ platelets per unit, instead of the standard specification of 240 × 10⁹ platelets per unit as a minimum. And when these platelets will be introduced will be a decision made by NHSBT, and it will use information about what the current stock levels of platelets are and what the predicted future stock levels are. So these won't be introduced if it's expected to be a transient entry into red alert that we recover very quickly from. It's when we're expected our stock levels to decrease dramatically, and none of the mitigations that we usually put in place are going to lead to an improvement without reduced dose platelets being introduced. Pooled platelet components will remain standard dose, and neonatal platelet components will not be affected. Next slide, please. So we released the product codes on the update on the 25th of January, and the platelet label clearly says it's a reduced dose apheresis platelets, leukocyte depleted, and you can see an example of the label here on a pack of platelets, but otherwise will appear the same and can be requested as irradiated if patients require it. Next slide, please. So, as I say, we're not going to use it in neonates and infants, but it's a reduced dose apheresis platelet component for older children, so at least 1 year of age, or adults who need prophylactic platelet transfusions, i.e. platelets to prevent bleeding. And without the need for a major intervention. And so this is usually going to be haematology patients, oncology patients who are having chemotherapy or a stem cell transplant. We've got good evidence from a randomized controlled trial called PLADO, which looked at different doses of platelets and showed that a low dose platelet component was safe. It didn't increase the risk of bleeding, but there was a lower platelet count increment, and patients may require slightly more platelet transfusions than a standard dose platelet component. If you've got somebody who needs platelets because they're bleeding or they're going to have major surgery, then you want to opt for using a standard dose component instead, if available. And that would be, it's easy if you're using pooled components because they're going to be standard dose. If you don't have any available, then what you can do is 3 reduced doses equivalent to a standard dose. With HLA or HPA selected platelets, during this kind of really kind of severe shortage of platelets, they may not be available. All of these requests will need to be approved by your local haematology consultant. And if we can't provide HLA or HPA selected platelets, then use random donor ABO matched platelets. Next slide, please. The reason why we've released the product barcodes now is to ensure that you've got time to update your LIMS or any other affected IT systems, such as blood tracking. Because we know it takes time for those to be uploaded, but we want to be prepared if there's any future impacts on the blood supply by future major industrial action, for example. When we implement reduced dose apheresis production, what we will be doing with hospital services is issuing those as part of oldest platelet components first. So you'll get a mixture of, depending on which platelets are the oldest. So you won't just receive reduced dose apheresis, and it may be only one blood group that is reduced dose, depending on the shortage. To enable the hospital services and NHSBT to provide platelets to as many hospitals as possible, what we are asking is that you only request pooled platelets for a standard dose for supply of bleeding, so for major hemorrhage packs, major trauma, and that you state that in the line notes when you're requesting on OBOS. I think there's a couple of hospitals that do irradiation locally, and if you do that, then you may need to consider your impact on local processes. But I think that's only a couple of big hospitals in London. Next slide, please. So I'm hoping that most of this session is going to be questions and answers to enable you to answer any questions that have been raised already or that you're thinking about. But if you've got any queries after this, please come to your patient blood management practitioner or customer services manager. And there'll be other information on the NHSBT blood stocks page. Next slide, please. And we're questions and answers.
Thank you, Lisa. So we have now around 20 minutes or so for to look at your questions and to put them to the panel. We do have also some questions that were submitted in advance, so we will split between the two. But now please feel free to use the chat function now to submit questions to the panel, and we will make our way through those over the next sort of 20 minutes. First question that's come in from Tim, is the size of the bag going to be the same? And perhaps Jane, maybe?
Yeah, hi. It's going to be the same size of bag as the bag that you currently get pooled platelets in. It's a few millimeters different from the one you get apheresis platelets in currently, but it's not something you haven't seen before.
Thank you very much. Just whilst those questions are coming through in the chat, and whilst you're having to think about the questions you'd like to ask, we can have a look at some of the questions that were submitted in advance. This first one, I think, is perhaps most appropriate for Dr. Estcourt. How to calculate per kilogram dose of apheresis platelets for paediatric patients? Is there anything different we need to be thinking about?
For paediatric patients, so there's more guidance in the documentation that's on the website, but it says basically you do the normal calculation per kilo up to the volume of a reduced dose apheresis component. So you do not give more than one reduced dose apheresis component.
Thank you. And Jane, if I may come back to you, is the cost of the reduced dose going to be different to the price of a standard dose apheresis platelet?
That's something I'm currently working with my finance colleagues on, and they are telling me it will be approximately 2/3 of the price of the normal standard dose platelets. I haven't got a final cost just yet though, but as soon as we do, we will let you all know.
Thank you. So one of the questions we had was around how we will record our stock in Vanessa to produce data for the blood stocks management scheme. Now, these platelets should just be treated like any other adult platelet dose. Just enter your stock levels for platelets into Vanessa as you would with any other platelet components. Another question into the chat. There is not much difference between the reduced dose labelling compared to a normal platelet. Can there be an added luggage label? Jay, may I come back to you to start with on that one, and if anybody wants to expand?
You can. We did consider an added luggage label, but we had hoped that the additional wording on the label plus the new product code would be sufficient to identify these in the hospital. The likelihood is, if there is industrial action, is that we will be short of staff in the labs as well, and it will be tricky to add additional labels to anything en masse, but we can consider it if we think it's necessary.
Absolutely. Thank you, Jane. Now, Craig, if I may come to you for this one, do we have to request specifically, or will it be a default issue unless we specify standard dose is required?
No, you won't order them specifically. I think, as it said in the slides, we will issue them our side against all orders that come through.
Thank you, Craig. How long from the amber or red alert being initiated by NHSBT will the process units become available? Will these new platelets, reduced dose platelets, become available? Lisa, may I come to you with that one, please?
I think it's going to be a case-by-case situation, that it depends on exactly the level and depth of predicted of the platelet shortage, about when it's going to be implemented. And once the decision to manufacture comes through, then it will be a few days after that before they start being issued. So there'll have to be a shift in manufacturing, and then in a few days after that, then there'll be a shift in issuing of the platelets to hospitals. But as to when, in relation to timing, it's going to be a case-by-case situation, and it will be only when we've used all other mitigation measures that we usually use to avoid shortages that would be considering this implementation.
Thank you. Coming to maybe Sasha, and again, maybe yourself, Lisa, if you want to add. If these are the only platelets available in stock, can we give them to bleeding patients and without this being shock reportable?
Yes, and I think Lise has, I mean, that is covered also in the INF guidance that Lise and other colleagues have worked on. So we're saying use the pooled platelets generally for ordering for, say, major hemorrhage or bleeding patients, because we know you'll always know that those are standard dose. But if you have only got reduced dose platelets in stock, then 3 reduced dose platelets, for example, is equivalent to 2 standard dose platelets. And so the advice would be use what you've got and use the minimum needed to reach the increment you wanted to achieve. So yes, you could, but we would advise having pooled platelets on standby should you need those for major hemorrhage, or somewhere, like you at King's, where you're a major trauma unit, you undoubtedly will need to have pooled platelets as well on stock. So hopefully that answers your question. I don't know if there's anything you wanted to add, Lise.
Yeah, I've contacted SHOT, and they are drawing together some guidance about what is and is not reportable in this sort of situation, and so that will be distributed soon as well.
Thank you both. Craig, if I may come back to you, there's a couple of back-to-back questions that we might be able to answer together. The first one is we've had experience of incidents where hospital services may have missed comments that are written into the order line and OBOS. Is there anything being done to avoid that? And a second question, can the reduced dose platelets be ordered on OBOS for those patients identified as requiring prophylactic platelets?
With the line notes one, we're working with hospital service colleagues to put a more robust process in place during a shortage or such times where we have to introduce these reduced platelets. It's not foolproof because the line notes aren't checked by our LIMS system in any way, but we are looking at how we can best improve that. As for ordering specific reduced dose platelets, as you say, it will just be the option of ordering a platelet and we'll supply what we have towards those orders. I'm not sure if we have to specifically supply reduced ones for prophylactics, but I'll throw that open to Lise for
no, the policy is we're just issuing oldest first, and it will be a mixture of what's available, and we will be using a kind of pool to provide stock for kind of major hemorrhage packs, things like that, and that you will specifically say in the line notes about asking for a pooled component for those reasons.
Fantastic, thank you. Are there any other storage or transport requirements that that affect this component's integrity? I don't know who may want to come in with that one. Perhaps either Jane.
Yeah,
maybe.
I can. So we haven't found any in NHSBT. The volume of the platelets is between that of the neonatal and the adult size, and we've validated both ends of that spectrum. So our assessment has been that these platelets don't require anything additional, but that is something you will need to look at individually in your hospitals. If you have transport containers that are only suitable for one or the other, for example, you will need to work out which one to use for these slightly smaller dose platelets.
Thank you very much. And maybe staying with you, Jane, just for this one, can we confirm that the volume in each bag is the same as a standard apheresis unit, but the number of actual platelets is lower?
No, it's the other way around. The actual platelet concentration is the same, the volume is lower.
Thank you. So, interesting question. I think perhaps Craig, in the first instance, will we be getting a call from NHSBT if reduced dose platelets are being issued on a case-for-case basis, so we can then seek authorization for their use? So perhaps the first part of that question is, sorry, Lise,
I think I've managed to confuse somebody. The actual implementation of a reduced dose apheresis policy will depend on the particular scenario, but we're not issuing, once we've made that decision, we don't issue on a case-by-case basis. It'll be a mixture of what you get. So do you see what I mean? It's kind of the whole shortage situation can vary, and we don't know quite what's going to happen in the future. I wish I had a crystal ball, but unfortunately I don't. But once that call has been made to produce reduced dose apheresis platelets, the recommendation we have is those are used for people who require prophylaxis in which is aligned to the recommendations on what use of prophylaxis should be within an amber and a red alert situation, according to the British Society of Haematology guidelines for platelet transfusions and the British Society of Haematology guidelines for children and in transfusion in children and neonates. So whether you transfuse or not is dependent on that. We are going to ask people, this is going to be a real severe shortage situation. So people will need to think about what needs to be referred to their local NHS consultant for decision about whether a transfusion should be given or not, because there's certain recommendations in the BSH guidelines about when you shouldn't be giving transfusions in a severe shortage situation that would be transfused normally. So those things need to be considered. And we would be saying if reduced dose are the only things available and you've got somebody bleeding or having a major procedure, then you'd need to give more of the reduced dose component if you don't have a pooled component.
Brilliant, thank you, Lisa. Quick question from Tim. Can you please share the slides? Yes, Tim, we will share the slides. We'll share some. We'll share a summary of the information that's been shared today, as well as this webinar being recorded and will be available to watch back as well. Technical question: are the reduced dose apheresis collected routinely and split into smaller doses in the lab? How many reduced doses can you get out of a regular double dose collection? Jane, may I first come to you with that one?
Yes, you can. So yes, it is a routinely collected apheresis dose that we would normally split into 2. In the case of needing to implement this plan, we would split it into 3.
Fantastic, thank you. I know Lisa touched on it briefly in the background information, but for hospitals that irradiate platelets themselves, can the reduced dose platelets be irradiated using the same process that they've already got established? I'll come to Sasha first and then come to Lisa.
I think just sort of following on from what Jane said earlier about the volume range being between that of neonatals and standard dose platelets, for probably most hospitals, if you're already irradiating both neonatal and standard dose platelets, there shouldn't be any change in your processes around irradiation. I mean, one thing you might want to consider, and you might already be considering with the new codes, is, you know, if you have an irradiator that requires scanning of codes into your new irradiator, that is before you can do irradiation, that might be something that you need to consider. But I think it would very much be a local matter of reviewing if there is any impact on processes that you have. I mean, to my knowledge, I think both of the trusts in London that currently do local irradiation treat both children and adults, so it's not likely to be an issue for you, but just something to consider when you're thinking around local implementation.
Brilliant, thank you, Sasha. Lisa, was there anything you wanted to add there?
And I think if you find that you can't do the processes quickly enough when this is implemented, then you can request irradiated from NHSBT instead during that period of time.
Brilliant, thank you. General question around risk and assessment of risk. Is there any resources that NHSBT can share, specifically a risk assessment with trusts around this new component? Jane, may I come to you on that?
I would have thought so. I would assume though that they would prefer clinical risk assessment rather than the operational implementation risk assessment. I'm not sure whether that was the line of question.
Would anybody like to expand on that? Lisa, perhaps?
I mean, the platelets are considered safe for prophylaxis. We've got a massive randomized controlled trial showing that it's safe in prophylaxis with this reduced dose, which is the best quality evidence we can get. We know it doesn't lead to a high increment based on that evidence, and we know that patients may need slightly more frequent transfusions, but we know it didn't lead to increased risk of bleeding if given in prophylaxis.
Thank you very much. So we have perhaps two or three more minutes for questions to the panel. It's like we have got through the questions that have been put into the chat so far. Does anybody have any outstanding questions? that they would like to put to the panel today whilst we have them on the call? Lisa.
I just read the note. It was to placate medical colleagues. I have to say that before this guidance went out, it has been reviewed by the British Society of Haematology and the Royal College of Pathologists, as well as NHSBT, who have endorsed and promoted the guidance on their web pages as well.
Thank you very much. Okay, a couple of new questions in. If there's no increased risk of bleeding with this new component, might it be considered standard in the future?
I don't know is the answer. But it might complicate things because we would need a mixture of reduced dose and standard dose in the future. So I think there would need to be major considerations before that was brought forward, and also impact on manufacturing, etc. So currently the plan is only to use it as a contingency component in a severe shortage situation. Whether that changes in the future would be dependent on a lot of further review and assessment.
Sasha, may come to you with this one. Apart from the wording on the labels, will the bags look obviously different to clinical staff?
I think this follows on from the earlier question, probably around the additional labelling of the platelet bags. So in terms of how whether the platelets will look obviously different, other than the change of wording on the label, and obviously the additional code that will be on the limbs, they won't look obviously different most of the time. Many of them will be a lower volume than the standard volume. The mean for a standard dose is 217 mils, and many of these will be likely to be a much smaller volume platelets, but there is crossover between the specification. So we can't say for certain that reduced dose platelets are always going to be a smaller volume than standard dose platelets. So that's a long way of answering your question, but in essence, other than the wording, the bags won't look different to clinical staff.
Thank you, Sasha. I made that 12:30. There isn't any additional questions in the chat, so I'll just spend the last minute just to grab where you might find some further information. Now, this Q&A session is by no means you know, the last and full support we'll be providing. A lot of information has been shared with your hospital transfusion teams, and we'll continue to share information and resources as they become available. Lots of those resources are posted onto the Hospitals and Science website as well, where you can go and access them as and when they become available. This meeting, this webinar has been recorded, and we'll look at getting that onto there as well, so you can watch this back. And as I said at the start, we'll go through all of the questions put into the chat and come up with a nice summary document that we can share with you as well. Your NHSBT customer service managers and patient blood management practitioners continue to be available for support should you need to contact them. We're always happy to help you where we can. So with that, that brings to close today's Q&A session. Thank you to the panel for joining us today and for answering those questions, and thank you to almost 100 of you who have joined us today for this session. It's been really interesting, and we really appreciate you joining us. Thank you very much.